This episode is supported by Arcutis Biotherapeutics, who champions meaningful innovation to address the urgent needs of individuals living with immune-mediated dermatological diseases and conditions. Learn more at arcutis.com.
Well, I'm Dr. Jim Rosso, dermatologist in Las Vegas, Nevada, and very happy to bring you a vodcast, The Tea with Dr. D, which falls under our podcast platform, Derms and Conditions. But you get to see the beautiful face of not me, but my good friend, Chris Bunick. Chris, it's great to have you here today. Thanks for being here.
Jim, thank you so much for having me. It's always a pleasure to have a scientific and clinical conversation with you.
Yep. I noticed you said scientific the word scientific first, because that's the kind of guy you are. But I just want to mention a couple of things about you. Chris has a very interesting past. He's homegrown. I mean, he's homegrown right there in the beautiful state of Connecticut. He did his internship, dermatology residency, and research fellowship at Yale School of Medicine. He was the research fellow in 2012, and then went on to be faculty at Yale School of Medicine in the Department of Dermatology, contributes on many different levels: clinical medicine, publications, presentations, and a lot of benchtop research that I'm glad he's doing instead of me. I would be dropping all the things that are in there. He's Associate Professor of Dermatology at the Yale School of Medicine, and he does benchtop research, laboratory work, and a lot of clinical practice seeing patients. So that's a great background. He did go to college at Vanderbilt in Nashville, and as such, he's a big Tennessee Volunteers fan, even though they're based in Knoxville at the University of Tennessee, and his father was born in Boston. So it hurts me to say that he is a full Boston pro sports fan: Celtics, Bruins, Red Sox, Patriots. So I'm not going to hold that against you during the discussion, Chris. So it's great to have you here today. Right?
It's hard not to follow championship traditions, and that's what Boston sports has. And hopefully the Tennessee Vols get back to their championship ways too.
Well, let's hope. I'm pulling for him too. I have a good friend, a dermatologist, goes to every game and has a box. Chris, We're going to toast to another episode of Tea with Dr. D. It's going well. What is that you're holding?
Oh, it's the beaker. It's the beaker that I always drink from when I'm in the lab. It's my drinking vessel.
I should have known. Why am I not surprised? Well, let's get started. Enough about us, and let's get started on the topic at hand. So there are many different mechanisms of disease states and drug therapy that we have. They keep adding on, and we keep trying to figure them out as far as where they fit in and how the therapies fit in, especially if we're trying to inhibit a certain cytokine or a receptor, and what that actually means in terms of treating the disease and how it might affect the patient. So today we're talking about phosphodiesterase 4. And phosphodiesterase enzymes, there are many of them, but specifically phosphodiesterase 4 has gotten a lot of attention in dermatology. But what is phosphodiesterase 4? What does it actually do? Why are we trying to inhibit it?
Well, Jim, phosphodiesterase 4 or PDE4, it's a hydrolase. That the simple word is hydrolase. Well, we know hydro, right? It's kind of the root word of water. So hydrolase, it actually uses water to hydrolyze or break apart cyclic AMP. Cyclic AMP is a very important intracellular messenger that helps drive signals in certain pathways within cells to execute ultimately different transcriptional programs. And at that level, elevated cyclic AMP really has or drives anti-inflammatory pathways that are very important to different skin behaviors in humans. So
that's part of the normal physiology, homeostasis.
The normal
right?
physiology.
So what about when there's dysregulation, the disease states where there's too much PDE4? Because that's what's going on in the skin and even in other tissues, but especially in the skin. What are we talking about? Why are we inhibiting it?
Well, we're inhibiting it because when you have, in the case of, say, atopic dermatitis, seborrheic dermatitis, psoriasis, an inflammatory disease, what's happening is you have overactive PDE4. It's degrading cyclic AMP. And the more you degrade cyclic AMP, actually, the less anti-inflammatory component you have. And so it actually allows these inflammatory dermatoses to take off because you're not signaling down the anti-inflammatory pathways that actually PD4 allows for at lower levels. At those high levels, you lose the cyclic AMP. It's a problem. So PDE4 inhibition, the goal of that, Jim, is to actually gum up PDE4 so that you end up preserving or increasing the levels of cyclic AMP. Then you
bringing it back to that more physiologic state, right? You're trying to turn the knob back. But I have a question for you with regard to the disease states, because I have a lot of people ask me, in the case of crisaborole, which is a PDE4 inhibitor, is approved for atopic dermatitis, and you have an oral apremilast, and we're going to get to some of these differences I have questions about, FDA approved for psoriasis, an oral therapy. And then we have topical roflumilast for the 3 disease states, right? We have plaque psoriasis, seborrheic dermatitis, and atopic dermatitis. And in different places, or I might have people email me or call me and say, what are we doing with this? Are we just throwing it out the wall and seeing where it sticks? How can PDE4 be involved in so many different diseases? It doesn't make sense. It's a little bit hard for them to wrap their head around it, but it does make sense. So can you explain that?
Yeah. So let me say it in a very simple way, Jim. The same way that JAK-STAT pathway is involved in a lot of inflammatory signaling pathways, so is PDE4. PDE4 and the JAK-STAT pathway are very similar in that they are linked to these different inflammatory pathways. We hear about type 1 cytokines or Th1, Th2, Th17. These different types of inflammatory pathways, PDE4 is upstream of all of these types of Th1, 2, 17, type 1, 2, 3 cytokines. So, we're talking TNF alpha, interferon gamma, IL-4, IL-17, IL-22, and 3. That is really mind-blowing. When you think about PDE4 regulating all these different types of cytokines, then you understand the power of PDE4 inhibition and that you're able to regulate those pathways.
So if you need to inhibit, let's say, TNF alpha or interleukin 4 or whichever IL-17, you're affecting each of those, they have roles in different disease states, and that's why inhibiting PDE4 will influence those disease states. Did I 100%. Pick that up right?
That is absolutely right. That is the power of PDE4 inhibition. Now, why did we not see, and we'll talk about this, but why did we not see such power across diseases and inflammatory disease states or pathways with crisaborole? Well, it's because roflumilast is designed different. It's way more potent. And so when you have that more potent PDE4 inhibitor, it's actually translating to better clinical responses. And now we're seeing the full benefit of PDE4 inhibition across dermatoses.
So that brings a point to mind, because a lot of times what will happen, and it could be in terms of seeing efficacy differences or even tolerability of side effects, which has a lot more to do with, or it has more to do with than just a molecule. It may be a formulation or a vehicle, whatever. But, when you have the first drug that comes out, a PDE4 inhibitor, that you're all excited about it because of the mechanism, but then you get a modest clinical effect, right? And then the next one comes out and people assume they're all going to be the same, but they're not. Like you said, there are differences in their actual strength. You have 3 boxers in a family, 3 brothers, right? But one hits really hard and one doesn't. You think they're the same family, but they have different strengths. So can you go through why those 3 molecules are different in terms of their potency?
Jim, you hit the nail on the head. As a clinician, sometimes you get used to the first drug in a class and you think this is it. This defines the whole class. But that's not what we're seeing in the PDE4 class of inhibitors. What we're seeing is that roflumilast has different properties than apremilast and crisaborole, and that is actually playing out clinically in what we see in terms of efficacy. So ultimately, the key point, Jim, I've published a lot of science and papers on this, but I want to simplify it for our audience. Cyclic AMP, when it normally binds PDE4, it uses a number of molecular contacts, but there's 3 key ones. It's shown there's a
By,
glutamine
molecular, you're talking about binding sites, correct?
binding sites
Binding
for
sites,
cyclic
okay.
AMP on PDE4. Some of the three key ones that I think clinicians should know, there's a glutamine, there's a hydrogen bond with water, and there's a metal binding site. Those three. Roflumilast mimics cyclic AMP's binding to PDE4 the best over apremilast and crisaborole because it mimics all three of those binding sites. And that gives it tighter binding. In fact, roflumilast binds PDE4 200-fold stronger than apremilast. And it's almost, I think, around 14 or 1500-fold stronger than crisaborole, which only has one anchor point compared to the three of roflumilast. There are clear molecular properties that distinguish these. And this is just the binding properties. As you said, there's vehicle differences. There's other differences that go into the final medicinal product. But from a purely physiologic PK, pharmacokinetic type analysis, this is a very unique molecule, roflumilast, because of the ability, the strength that it has to bind PDE4, because it's mimicking cyclic AMP. The difference is PDE4 can't hydrolyze roflumilast like it can cyclic AMP. So this is ultimately gumming up PDE4 or inhibiting it. And that allows the cyclic AMP levels to stay high. And then it affects those cytokine pathways. It allows kind of a dampening down of Th1, Th2, Th17, et cetera, cytokine pathways.
That are influencing all those different diseases. Okay,
That's
Dr. Bunick, we've all had presentations, and I'm going to play the role of that person in the crowd that says, I heard about this guy Bunick. He's a big hotshot. And they're that, throwing the wrench in it, and they're challenging you. They want to catch you on something. Oh, that's great, Dr. Bunick. You have all the science in the laboratory. But what does this mean to me in the clinic, right? And, we have patients, for example, with atopic dermatitis, and they have very severe disease, and we're utilizing systemic therapies. Maybe lesser cases, the topical therapy alone with a nonsteroidal might get the job done, right? In many cases. But now we have patients that we have them on systemic therapies or a biologic. What's this going to do? Because we obviously need topical therapies in those patients. So I don't see how this applies. Do you have any examples?
Well, so Jim, actually, I do have clinical examples. This is a patient of my own that I saw early on when roflumilast first came out. This is a patient who had long-standing, very painful palmoplantar pustular psoriasis. She had tried several biologics, was ultimately on, at the time, an IL-17A inhibitor, and a selective IL-17A inhibitor, just to be very clear. And she was still having a lot of trouble ambulating because of pain. She still had pustules on her feet. And I had tried topical clobetasol. I had tried betamethasone. I had tried a number of steroids to try to have adjunctive therapy to the biologic. And she was still struggling. And I said, well, there's this new drug for psoriasis, a topical. It's a non-steroidal. Let's see how good it is. And I'll be honest, I had a little bit of reservation at first when it came out. Oh, how's it going to be different than crisaborole? But I put her on their topical roflumilast, the 0.3% cream, which was the indication for, adult psoriasis. And lo and behold, her feet cleared. Her pain went away. She was able to ambulate.
How long did it take to kick in?
Yeah, so I think somewhere between 4 to 8 weeks is when she noticed the improvement. And Jim, this was 2 or 3 years ago. I presented this patient at the World Congress of Dermatology in Singapore. So it's been a couple years. She's still on topical roflumilast because it's still working for her. And I think that's the testimony. Not only was it powerful, did it work? It's durable. And importantly, when someone has a chronic disease, it allows her to stay on a non-steroidal chronically for long periods of time. We don't have to put her on a high potency or super potent topical
and then be
steroid.
Concerned about how long they're using it. But another point, clobetasol obviously has been around and we see it being effective, but you can't use it for a very long time. And a lot of people don't realize when you withdraw it, it leaves behind a lot of barrier impairments, decreased lipid synthesis, and there's data to show that when you stop topical corticosteroids in some of these inflammatory disease states, that the patients seem to have quicker onset of recurrent disease. Is that something that you perceive may have happened in this patient?
Well, it's possible. I think in this patient, there just wasn't any clinical response at all.
Right.
But I agree with you. Barrier integrity, a lot of people don't realize chronic steroid use compromises barrier integrity. But with roflumilast, there's actually evidence of restoration of barrier integrity, especially in the seborrheic dermatitis transcriptomic data. And I think that is really key to remember, is that there is this barrier improvement as well. And you can see it in the pictures of this patient's feet here. And I can tell you, even more important than the image of the feet was just the lack of pain, her ability to have some of her life back. And I think as a clinician, that's one of the most important, powerful things that drives how I select what medicines I use. When patients have really powerful stories that have changed their life, it makes you say, well, I'm going to try that medicine again in someone else.
Yeah, absolutely. So, Chris, with the move to nonsteroidal agents, and obviously, I mean, I practiced for years when we only had topical corticosteroids and moisturizers. So we had to figure out ways to utilize topical corticosteroids. They were very effective when used for short courses, but we had to make sure we were stopping them. We knew about all the possibilities with the adverse effects of topical corticosteroids. And if patients happened to get on them too long, they actually had more significant problems over prolonged use with what we call a withdrawal syndrome. But we talked about 3 different disease states: psoriasis, seborrheic dermatitis, and atopic dermatitis, where PDE4 inhibition, amongst some other pathways that you have listed on that very nice slide you put together. But there are other disease states, even beyond the FDA approval. There were some case reports in JCAD that we had recently, and there's some other literature on PDE4 influencing pigmentation pathways. And these were young kids that had been utilizing even approved topical therapy for vitiligo and some other treatments that still had persistent vitiligo patches on their face, that the parents were coming in at 3, 4, 5 months and saying, is there anything we can do? And utilizing topical roflumilast really helped push along repigmentation in some of these kids. How is PDE4 influencing hyperpigmentation or pigmentation pathways?
So, Jim, I've had the same experience. I have a patient, an adult patient between 30 and 40, female, that had some vitiligo on the face, and topical ruxolitinib was not quite getting her where she needed after 6 months. And so I ended up switching to topical roflumilast. And within 4 weeks, she was already seeing significant repigmentation. And I saw this in my patient and I was like, wow, what is going on? There may be more, but at least one possible explanation is that the melanocortin-1 receptor pathway does signal through cyclic AMP, or it does use cyclic AMP to drive its signaling to increase eumelanin production. And that may be one possible pathway where intersecting with PDE4 and cyclic AMP could increase eumelanin production.
So what's so interesting to me is our cells are very efficient. They utilize some of the same compounds or entities to do a lot of different things. And that's how we find out about it. We tend to think about a cytokine or a pathway being involved with what we understand. And then we find out, hey, cyclic AMP is being used over here in another pathway. We find out about it because we fall on it, right? We fall into it. And there actually are some publications on the pigmentation.
Yeah.
But Chris, I'm going to move on now to talk about formulation. So Chris, you've helped me understand what's behind roflumilast as a PDE4 inhibitor, what makes it different from the others, and how that translates into clinical practice in terms of what the drug can do. And a lot has to do with its inherent potency, but there are other features, and the vehicle is a very important part of it, right? So one of the things that we see is the delivery into the skin. It's a very small molecule. It can get into the intercellular spaces, so it can get into the epidermis, but it's also highly lipophilic, so it can migrate and become consistent with the lipid bilayer. So all of that is very important in the vehicle formulation. But when you look at the physiochemical properties, I'm sure you'll agree, it's good that it's a small molecule, makes it easier to get into spaces. It's lipophilic, which allows it to mingle successfully with the lipids, right? It's water insoluble. Now that creates a problem to put it into a water-based vehicle, because if you put it in a lipid vehicle, it becomes very messy and very sticky. So let's look at what makes it unique. So this was a study that was done by Zoe Dralos. She had 40 patients. It was inter-individual assessment that she did. So one leg was treated with the roflumilast cream vehicle, and the other was treated with a commonly used ceramide-based moisturizer. And these patients were followed over 17 days, but they applied either of those to whichever leg was designated for 15 days. And for the first 5 days, it was done at the clinic, but then the patients are instructed and they had properly labeled product, but they didn't know what was going on which side, and either did the investigator. And they looked at transepidermal water loss, which is a measure of barrier integrity, right? If you have increased transepidermal water loss, the barrier is not functioning as well. They also looked at corneometry, which measures the moisture that's kept within the skin. And they looked at assessments by the investigator and the patient of different characteristics, how it felt, how it looked, irritation levels. And they, at week 15, the primary endpoint was the transepidermal water loss. But if you looked at all the parameters, except on day 1, where the tool was positively affected more by the moisturizer than the vehicle, everything else pretty much turned out to be about the same. So this vehicle, we're not suggesting it be used as a moisturizer, but it's very barrier friendly. Pretty much the same as if they had been using a very well accepted ceramide-based moisturizer. So what makes this vehicle unique? There are several things that make it unique, and being able to form my cells while it's being produced is extremely important. That's done at very high temperatures, and that allows the roflumilast to be housed on the inside of that 2-layer micelle, so it's in the lipid portion where it needs to be dissolved, but the outer portion is aqueous. So now you can create an aqueous vehicle. So that leads us to the next discussion, where it's an aqueous-based cream containing a very lipophilic compound. And they did that by utilizing different excipients, how they could solubilize it. They used an emulsifier system that had never been used before, but the significance there is when it comes down to room temperature and it's at the skin level, those emulsifiers do not solubilize the ceramide and the lipids. So it's not doing it on the patient, but it had to do it when it was being made in order to get the roflumilast into that formulation. But one of the things that's not commonly asked, right, is the pH. Why is the pH of a formulation so important? Because this is formulated at the same range of pH that the skin is at. So I know you've mentioned this to me several times. This is extremely important. So what's your take on that?
Well, Jim, I agree with you. Number one, we often hear the skin referred to as the acid mantle. People talk about the acid mantle of the skin. Well, it turns out our skin has an acidic nature. That's why its normal pH is around 5.5. Well, in the case of roflumilast, the formulation is pH 5.5. Having that match of pH with the skin is incredibly important for promoting barrier integrity and not causing irritation, not causing any type of formulation problems that irritate the skin. It improves the tolerability of the product. And second, that also plays into the fact that the emulsifiers you mentioned they're non-ceramide stripping. So as you preserve the ceramides and you actually preserve the barrier because you're compatible pH, that goes a long way to making a highly tolerable product. And that is what we really have with roflumilast, whether it's the cream or the foam. We just don't see a lot of irritation. And I think that that's because it was well thought out, thinking about the real normal physiology of the skin.
That formulation, they didn't just fall on this. These components of the formulation, in addition to the roflumilast, were done with this in mind. But then they had to prove it. They had to prove that this translated to clinical relevance. But I just want to point out that acid mantle pH favors the normal range of the cutaneous microbiome. If you get too alkaline, you favor candida overgrowth, you favor bacterial overgrowth. If you get too acidic, well, nobody wants to feel sulfuric acid or hydrochloric acid on their skin to the extreme, right? But how did this translate to the tolerability of the studies? I know we have done some poster publications on this. So can we end with summarizing that?
Yeah, Jim. So if you look across the number of studies that roflumilast has been done in terms of clinical trials, across all those clinical trials, if you look out at tolerability, looking at things like erythema, burning, stinging, itch, at the compared to baseline at the 4-week and the 8-week mark, the tolerability of this product is in the like 97 to 99 to 100%. We are just not seeing a lot of irritation with this product. And I can say, we talked a little bit earlier about using roflumilast on the face for vitiligo in one of my patients. Just the ability to use either the cream or the foam anywhere on the body just speaks to that tolerability. And that's what the clinical trials have shown consistently.
Right. And the fact that we have the cream and the foam can be used anywhere. The cream could be used anywhere, but they do have some specific indications, like the foam. Seborrheic dermatitis is commonly on the scalp, and it spreads more both of them spread well. You can use the cream on the scalp, but the foam is going to be easier to get into the scalp between the hair in individuals that have a lot of hair. And so it's very important. Both of those formulations really have the same low irritation potential and adverse event potential. So that's extremely important. So Chris, thank you so much for that. Before we get on to Dr. Lisa Swanson, who's going to talk about the pediatric patients and their managements, let's get a word from our sponsor.
This episode is supported by Arcutis Biotherapeutics, a medical dermatology company focused on developing meaningful innovations in immunodermatology. We are advancing the understanding of the pathophysiology of seborrheic dermatitis. Learn more at arcutis.com.
So we're back with our Tea with Dr. D episode, and I have a special treat today. I have one of the world's best and most loved and very, very talented pediatric dermatologists, Dr. Lisa Swanson. And Dr. Lisa Swanson, it's going to sound like it's another planet, but it is a state in the United States. It's the state of Idaho. She practices in Boise, Idaho at Ada West Dermatology. And she is also a pediatric dermatologist at St. Luke's Children's Hospital in Boise, Idaho, the home of the Blue Smurf Turf. So, Lisa, thanks a lot for being here today.
Oh my gosh, honored to sit here having tea with Dr. D. I can't believe I'm here. This is amazing.
So, Lisa, I just grabbed my cup. Do you have a cup?
I don't have a cup.
Oh,
I thought...
I guess with the government shutdowns and everything, the mail wasn't delivered. But I'll get you a Tea with Dr. D cup, I promise.
I'll remember. I'll remind you. If I don't receive it, I'll remind you. Yeah.
Please do. Please do. So, Lisa, my understanding in pediatric dermatology, it starts at the day of birth, as soon as that child is born.
Yes.
And pediatric dermatologists sometimes go to the upper end of age, but yours is age 18, you said?
Yes, roughly. I see a few patients above the age of 18 if I feel like they still need me. They might be over 18, but maybe they have a pediatric dermatology ailment. But the majority of my practice is under 18. Yeah.
Right. But a lot of them must be crying when you let them go, because they just don't want to leave.
Oh, that's sweet. That's sweet. I mean, I hope that they enjoy seeing me. I hope that it's a pleasant experience. I do have a lot of toys in my office, and I think that helps.
I've heard a couple of things that a few people didn't like you, but the vast majority do. So that's very, very good news. I'm pulling your chain. But, but talking about pediatric patients with atopic dermatitis, that's obviously a very common group. It often starts in very young children and continues throughout the pediatric years, often even beyond into adulthood. But There was a time when we really didn't have much other than maybe some moisturizers and different strengths of topical corticosteroids, and we had to manage that. But we found out very quickly we didn't like the corticosteroids in the long term, and we're not there anymore. But there was a period of time, even with some of the earlier non-steroidal agents that we had, they just did not hit that bar. And we often had to continue using corticosteroids intermittently, but it was always a challenge because corticosteroids have their drawbacks if they're used beyond a very short course. Going back to some of those older therapies, what were some of the limitations as you saw it as a pediatric dermatologist?
Yes, looking back, there were a lot of limitations to the tools in our toolbox, but it's all we had. And so we made them work, we put them to work, and we wanted to help patients. And so, of course, we utilized them. But they had a lot of limitations. The biggest one that has emerged over the past several years is steroid phobia. So many patients and their families are very afraid of topical corticosteroids based on the things they've read on the internet or seen on TikTok. They've heard about topical steroid withdrawal. They've heard about skin thinning. They're very nervous about the use of topical corticosteroids. And I think topical steroids still have a place. There is definitely still appropriate ways to use them. They definitely still work in a lot of situations. They're very cheap and inexpensive, and that's always a benefit. And so they still have a place, but we have this huge population of patients that is fearful of them. And so being able to offer additional options is so important in order to find a treatment plan that everybody is most comfortable with.
Well, the way I also think about it, Lisa, is even if you're going to use the topical corticosteroids, it's for a very short course. Yeah. And regardless, you're going to be utilizing nonsteroidal therapy in pretty much all cases because you're not going to continue that topical corticosteroid beyond a very short period of time if you're even going to need it.
Absolutely. Right? And that actually leads to another limitation from our old things, the complicated regimens that we would create. I feel like sometimes I'm in confession saying, my name is Lisa Swanson, and I previously prescribed the following regimen. Use hydrocortisone 2.5 twice a day to affected areas on face and folds. Use triamcinolone 0.1 twice a day to affected areas on the body. Use topical calcineurin inhibitors once or twice a day for prevention and maintenance. Use topical mupirocin if something looks infected. And remember to moisturize. That is way too much stuff. Way too much stuff.
And I have some on the scalp, so now I need a solution, fluocinolone solution or something.
Yes.
You got 6 things and they mixed them all up.
Yes. And then we also had to combat a lot of stinging and burning, particularly with our non-steroid options. The topical calcineurin inhibitors often had some stinging and burning associated with them. And then crisaborole was really notorious for stinging and burning.
Right. That was a later one and one that we look forward to. But a significant number of patients had stinging and burning. The ones that didn't did fairly well, but a lot of them did. So let's move to what we have available with the nonsteroidal agents. We have 3 newer nonsteroidal agents. Can we go over some of that?
Yes, it's an exciting time to be practicing pediatric dermatology and dermatology in general, and an exciting time to be treating patients with atopic dermatitis, because if families express a desire to avoid topical corticosteroids, we have some wonderful options to offer them. We could consider topical tapinarof, an aryl hydrocarbon receptor agonist, which is approved down to the age of 2. We could consider topical ruxolitinib, which is recently approved down to the age of 2, which we're very excited about. And then the focus of our conversation today, we have topical roflumilast 0.15% cream approved in various formulations for various indications and has been a really nice addition to our toolbox for inflammatory skin disease.
And certainly for atopic dermatitis. And the first entry was a 0.15% cream for mild to moderate atopic dermatitis. And that was a welcome addition.
Yes.
But the formulations that we had, both the cream and the foam with topical roflumilast, were always a 0.3%, whether it be for psoriasis or seborrheic dermatitis.
Yes,
right?
yes.
But now we were talking about a 0.15% cream.
Yes.
6 years of age and older was where that started. So can you explain why we're dropping the percentage of the topical roflumilast?
Yes. I always say the most complicated part about topical roflumilast is keeping all the strengths and indications straight. So we have the 0.3 cream, which is approved for psoriasis age 6 and up. We have the 0.3 foam, which is approved for sebderm 9 and up, and psoriasis 12 and up. And we have the 0.15 cream, which is approved for atopic dermatitis age 6 and up. And so this was formulated with tolerability in mind because this medicine is a topical phosphodiesterase 4 inhibitor. And as we mentioned a little bit earlier, we had some burning and stinging with our previous PDE4 inhibitor, crisaborole. So this was something that was very front of mind. We needed this to be a tolerable formulation, a tolerable cream for our patients with atopic dermatitis who are already prone to burning and stinging. And so a lot of attention was paid to the vehicle and the formulation of these products, and it paid off because these topical formulations are incredibly well tolerated.
They're extremely well tolerated regardless of the diagnosis, the concentration, the tolerability is exceptionally good.
Yes.
Right? In the high 90s, regardless, even atopic dermatitis, where you tend to see more skin sensitivity. So walk me through the 0.15% cream for atopic dermatitis.
Yes, so the 0.15% cream is approved for mild to moderate atopic dermatitis, patients age 6 and up. It's a once a day steroid-free preparation. I have my patients apply it at bedtime. And we have had good experience with this agent over the past several months, and patients love it. The vehicle feels nice, and so the product feels nice, which is everything. If somebody applies something and they don't like the feel of it, they're not going to use it. And this has been very well tolerated amongst my patients. And so kids are happy, parents are happy.
Does it kick in pretty quickly in terms of the efficacy across the board in your experience?
I think that it does. You know, I think we're in this competition right now where everybody wants to be the fastest thing. And it's hard to always have a fastest thing. And so I think that all of our topical nonsteroid options for atopic dermatitis work in a reasonable amount of time. I think that for the longest time, our nonsteroid options fell short in terms of how quickly they improved things. And that was a real benefit to topical corticosteroids, was their speed. But I think now with this newer generation of topical nonsteroidals, I think we're getting close to that speed of a topical steroid without being a steroid sort of situation.
Now, what I see here in my experience with topical roflumilast, really for all the indications, but certainly for atopic dermatitis with the 0.15% cream, is many of the patients kick in pretty quickly within that first week. Some may take a little bit longer, but there's a progressive continued improvement. And the longer they go, the better they're doing. They're getting better and better, and they can use it wherever they need to for as long as they need to. So I'm not worried about, I need to see them back. I put them on a corticosteroid. Where are they applying it? If they break out somewhere else, like if they didn't have it on their face, right? A lot of the kids get it on their face, and they do break out on their face, and they put it there. Lisa Swanson's not concerned about that, but she may be concerned about that with triamcinolone.
Very true,
right?
Very true. Yeah, and I think it is worth special mention that the primary endpoint in the roflumilast studies was at 4 weeks. 4 weeks, just a month. I mean, that's fast. That is fast to expect your patients to reach the primary endpoint as early as 4 weeks. That's pretty great.
So we now have down to the age of 6. But there are a lot of patients under the age of 6. Atopic dermatitis often starts before, very, very early in life. Yes. So can you talk about the 0.05% cream also applied once a day?
Yes.
For children with atopic dermatitis.
Yes. So this is so exciting. So we have a lot of patients under the age of 6 with atopic dermatitis, and a lot of those patients and their families desire a steroid-free topical option. And so enter roflumilast 0.05% cream. So yes, it's another formulation that we will have to learn how to keep straight, but this is ideally suited for our younger patients, age 2 to 5 years old. When this molecule was being studied, studied, they thought it prudent to utilize a lower strength for patients with atopic dermatitis as compared to psoriasis, and an even lower strength for the younger patients with atopic dermatitis because of the decreased skin barrier function, increased kind of penetration of the molecule. With phosphodiesterase 4 inhibition, you sometimes see a little bit of tummy upset or a little bit of headache. And so in the interest of keeping those numbers low and keeping efficacy high, they thought it reasonable to go ahead and lower the strength. So we're looking at a 0.05% cream for patients aged 2 to 6 years old.
So as they get smaller, there's the body surface ratio with application is different in the younger children. So I think the fact that roflumilast is such a potent molecule and really pretty much most of it's sequestered into the skin, you're going to get the efficacy out of that lower strength, and going higher doesn't improve the efficacy, but you're putting in an extra cushion of safety, if you will, to try to avoid that occasional patient that might absorb more and get, like you say, some GI upset. So to me, it made sense. And it's not the first time we'd had different strengths. We had it with topical tacrolimus. We have it with oral antibiotics, cephalexin, different age groups. You know, we utilize, as they get younger, different strengths. So I don't think this is not the first time that we're seeing this. So can we talk about the 0.05% cream?
Yes.
Some of the observations?
Yes. So this was studied in patients aged 2 to 5 years old in the INTEGUMENT-PED phase 3 trial. They looked at patients with mild to moderate atopic dermatitis. The majority had moderate AD. The mean BSA was greater than 20%. And I think that's worth special mention because that was the mean. So there was a bunch of patients with more than 20% BSA affected. 50% of the patients had facial involvement and 20% had eyelid involvement. I think that's really important to note because with a non-steroidal agent, you want to be able to use it, as you said, anywhere. You wanted to use it anywhere that the patient has atopic dermatitis. You want to make sure it's tolerable and effective on the face. You want to make sure it's safe on the face. And so it's nice that these patients were well represented with facial involvement and even eyelid involvement.
No, it's interesting because you're thinking about, we certainly have a lot of discussion about systemic agents in adults and even in adolescents. And you're thinking about more than 20% body surface area. When you see that patient, and they have a lot of itching and extensive body surface area involvement, we're automatically thinking systemic. But when you're talking about those little kids, for years, we primarily treated them with topical therapy.
Yeah.
Right? Because their body shape, it's a different patient. It's a different situation.
It is.
So,
and it's nice to see a topical well studied in a patient with larger BSA affected, because we know that topical ruxolitinib is limited to 20% BSA application. And we know that, dupilumab is approved down to the age of 6 months old, but a lot of parents and kids aren't enthusiastic about having an SHOT. So having a topical that's been well studied in patients with significant BSA, that is really remarkable.
I got scared because when you said HH, I thought you were going to spell a different word. I'm glad. I appreciate that. This is a general audience, okay? That it's a GP, right? So, what about the efficacy of the roflumilast 0.05%?
Yes, so the roflumilast 0.05% cream formulation really delivered on the endpoints of IGA success, IGA clear or almost clear, EASI 75, and itch improvement greater than or equal to 4 points. They looked at these endpoints with the primary endpoint being at 4 weeks, but they also looked at success at 1 week and 2 weeks. And so we can see that this molecule performed very, very well, especially with being a topical, non-steroid, once a day in a very tolerable emollient base. We're very pleased to see that 25% of the patients at week 4 achieved IGA success, meaning IGA success 0-1 and greater than or equal to 2 grade improvement. And 35% achieved IGA clear or almost clear, 40% achieved EASI 75, and 35% achieved itch NRS 4. Going even further on the mile marker of itch, improvement in itch was noted as early as 24 hours after application, which all our patients can appreciate.
And there we're talking about that separation versus the vehicle. And it's in a very good vehicle. Yes. In fact, the cream vehicle, the 0.3% cream vehicle, was studied by Zoe Draelos in a blinded way, side to side comparison, and had the same moisturization characteristics of a ceramide-based moisturizer. Now, we're not telling you to use roflumilast as a moisturizer, but being very, very barrier-friendly, that's impressive in and of itself. And the roflumilast is making it that much better, and they're continuing over time. So I'm just repeating what I have observed. Did you see anything different?
No. I think those points are well taken. Yeah. When Arcutis was developing this molecule and developing the vehicle, they recruited a master formulator to create the absolute best vehicle for this active ingredient to achieve these desired outcomes. And they really succeeded. They created a wonderful vehicle with very good emollient properties. And then you add the active to it and it's magic.
I know him personally. I was in a lot of communication with him during that process. I'd like to say that I gave him some of the ideas, but he didn't. I didn't. He came up with it all on his own. But what about, okay, I'm going to play the devil's advocate. Okay. Dr. Swanson, I read about you online. You're a big shot. Okay, big shot. How are we going to keep this under control? My kid's doing better.
Yes.
But we know from experience this keeps coming back. So what do we do now?
Yes. So I think a lot of us have incorporated a maintenance routine when we're talking to families about the importance of keeping the atopic dermatitis under control. We have plans for flares, and then we have plans for when things are okay to help keep them okay and reduce the overall amount of time that they're having to spend controlling the atopic dermatitis. And so the Arcutis folks took that into mind and created that as a part of their atopic dermatitis open label extension model. So if patients were able to achieve IgA 0 clear of their atopic dermatitis, they were switched into a maintenance routine of using the roflumilast twice a week. Now, one side note, looking back at the data for the roflumilast 0.15% cream in patients age 6 and up, in those patients that were switched to twice a week usage, they found that 57% of those patients didn't have to go back to daily use for a year. That is pretty darn cool.
So to put this in context, the investigator global assessment, they're clear or almost clear, which is practically clear. Yes. And now they're instructed in those areas where they had the disease, even though they're better or even completely clear, they continue to apply the roflumilast cream to those areas twice a week. And in doing that, it's a preemptive therapy. It keeps them from flaring and having to go back to daily application or more diffuse application, correct?
Yes. And in the littler kids, the 2 to 5 year olds, the median duration of disease control with twice a week application was 238 days, which is about 2/3 of a year. Fast math in my head.
Well, that's pretty good with the fast math. I'd have to use a calculator or something, right? But if they need to be using it more often, like we said earlier, it's okay because the safety of it, you're not concerned about any, unless they've had a local tolerability reaction, which is rare, that has gotten in the way of using it. They're free at sailing.
Absolutely.
It doesn't matter if they're using it every day. It's just nice that if some of them can use less frequent application and stay clear, it gives them that opportunity to do that. That's great.
I think this data is really meaningful because the other topical non-corticosteroids, tapinarof and topical ruxolitinib, they haven't been studied in this fashion. So I think this really is a strength of roflumilast, that it gives us not only an option to treat the flare-ups, but also an option to keep the kids clear.
Right. So all the efficacy stuff sounds great. You continue using it. Most people are going to continue to improve and get well controlled. We have maintenance therapy options, but let's drill down on the safety and tolerability data. So we have the 0.05% cream we're discussing as an example. Can you go through that?
Yes. So they looked at this with the 0.05% cream in the patients aged 2 to 5 years old. They found low rates of application site pain, which I think is on everybody's mind. I think the biggest pitfall is people thinking of roflumilast as just another PDE4 inhibitor. It's different, both in terms of its efficacy and in terms of its tolerability. And so don't let the crisaborole experience kind of flavor your opinions on roflumilast. It's its own molecule and in its own
its own formulation.
Yes,
its own formulation.
Exactly. And so this is a different medicine. And so they found low rates of application site pain, less in the active than in the vehicle. Adverse events included upper respiratory infection. Of course, these are kids, and then a little bit of tummy stuff with a little bit of diarrhea and vomiting. And so overall, well tolerated with excellent safety.
Good to hear. So overall, everybody should do well and have a good result.
Yes.
Well, it looks to me like we've done everything we need to do, but is there anything left in the development of nonsteroidal topical therapies to look forward to?
Yes, Dr. Del Rosso. Just wait. There's even more to look forward to. So we are, all of these wonderful options that we have for patients above the age of 2, we have almost nothing under the age of 2. And I'm hoping that that will change soon because roflumilast is in trials for babies aged 3 months to 2 years of age. And so excited for that. It would be really wonderful to have a steroid-free topical approved in this age group that actually had some reasonable efficacy and some good tolerability because, of course, crisaborole is approved down to 3 months old, but it's very hard for the babies to tolerate.
Yep. And so, yes, we do have that one topical crisaborole approved down to 3 months. That's still an ointment base, though,
It is. It's an ointment base, which is pretty messy. And, I've noticed a lot of the stinging and burning, especially in little babies with crisaborole.
So you've had that experience.
Yes.
Right?
Yeah.
So that's fantastic.
Yes.
As always, Lisa Swanson brought it to light. It's always interesting that people call me Dr. Del Rosso. I must be like that old school teacher, that you have to be real formal with.
It's a sign of respect.
You could call me Jim.
Oh,
you could call me Jim.
Yeah, I appreciate that, but it's just like I just can't. I respect you so much. You're Dr. Del Rosso.
Well, that makes me feel good. I fed you that. I fed you a softball, not a golf ball. But you could hit a golf ball out of the park.
I could. Yeah.
But I have a question for you. I've asked you one time in the past, because I know you love watching sitcoms.
I do.
You and Larry love watching sitcoms.
In fact, I think 100% of the times that you have called me on the phone, Dr. Del Rosso, you ask me what I'm doing, and I'm like, oh, I'm watching this sitcom with Larry.
Or you were watching some Bachelorette, Golden Bachelorette.
Definitely.
Or whatever
Yeah, there's definitely that. Yeah.
So I asked you your 3 favorite sitcoms.
Yes.
And of course, being Lisa Swanson, you had to push the envelope and get 4 for 3. So you gave me 4 names when I asked for 3. Golden Girls, Parks and Recreations, How I Met Your Mother, and 30 Rock.
Yes.
Now the phone rings and you pick up the phone and they say, "Hello, I'm John Smith and I'm a talent recruiter for television."
Oh my gosh.
And you've been invited to be a guest individual to be on which one of those 4 sitcoms you choose to be a guest on that show, appear on that show as a special actor on the show. Which one of those shows would you want to be on, and what kind of part would you like to play?
I think I would want to be on Parks and Recreation. And I think part of it is because Leslie Knope is my spirit animal. And so it would be so fun maybe to play like her future daughter, like her daughter that grows up. Like that would be really cool. And then B, there's a character named Ron Swanson on Parks and Recreation, and my last name is Swanson. So for those 2 reasons, I'd pick Parks and Rec.
It sounds like that was made perfectly with Swanson, and going back in the years, we can advertise Swanson frozen dinners.
Yes, right. Yes.
People, probably half of the people that listen to this podcast, the video podcast, don't even know what Swanson frozen dinners are, but we know what they are.
Well, and sometimes I tell people Swanson, like the chicken broth, which everybody knows because of Thanksgiving.
Sounds good. Lisa, thanks so much for your time, and this is a great discussion, and I really appreciate it. I'm sure I'll be coming back to you again.
Awesome. Thank you so much, Dr. D.
This episode is supported by Arcutis Biotherapeutics, a medical dermatology company focused on developing meaningful innovations in immunodermatology, including investigating new treatments for children and adults with atopic dermatitis. Learn more at arcutis.com.